we're going to talk a little bit now about mast cells. I know that should be of interest to some of you all, but we've got a couple very good sessions to discuss mast cell activation disorders and some cutting edge research related to mast cell activation disorders. That's a whole conference on its own, but we do know that EDS and mast cell disorders are interlinked, and we want to understand them as in those conditions as best as we can. So for our next speaker is Dr. DeLisa Fairweather. She has been my mentor, director of research at Mayo Clinic. She was pivotal to starting the EDS clinic at Mayo Clinic in 2019, which we just heard from Dr. Bruno all about. And her research is going into the understanding better of mast cells and mast cell activity. Dr. Fairweather is a professor of medicine at Mayo Clinic, and she's a leading researcher in immune-mediated and inflammatory disease. Her work focuses on the role of the immune system in chronic conditions, including autoimmune disease and Ehlers-Danlos Syndrome, and of course, mast cell disorders. So I know that it will be also practice changing, the research that Dr. Fairweather is doing, and I'm very grateful to welcome her to the stage. Dr. Fairweather.
It's so exciting to be here. And I just want to follow up with the last talk for a second, because I want to make what I think is a really important point, and it makes a good example. So I'm a patient also, and had pelvic congestion issues. So I've had 20 plus, who knows how many symptoms, like every symptom you could have probably in that area. And really it took several different departments and specialists before I got a breakthrough. And so just as an example, very quickly, is that one thing I had was a chronic urinary tract infection over 2 years, longer than that, I think. And it took open doctors and infectious disease, because everything about it was atypical, to finally get me on like permanent antibiotics. One part. The other thing is my tailbone was completely out. It took pelvic floor to put it back in and teach me how to keep it in. And then I had like more pelvic congestion, where my left renal vein was compressed with fibrosis partially, and just led to enormous numbers of symptoms. It took openness there, because that wasn't even any of the typical things we're looking at, and we're doing advances at Mayo in that area. And they're like, well, what is this, you know? So one of the things that we're really trying to do at Mayo Clinic is build experts in all of our referrals that become familiar with all. One, they have to be open, right? Physicians or other caregivers, and to look, because everything weird, unusual, atypical is the standard for EDS patients. And so they have to be open, and then also to become experts. And one of the driving ways we're doing this is including research and making them evidence-based research experts, because one of our challenges is the unopened doctors, right? The regular people who are unfamiliar with this. And as we produce high quality publications, we can hopefully then start to change the landscape and have it so that people will then be able to accept what's really going on, right? So that's a major goal of what we're trying to do. So my background in my whole career is in virus-induced myocarditis. And what was really interesting there in that whole field is that I realized mast cells were important in every stage of the disease, innate, acute, chronic, but I'm the only person in the myocarditis field worldwide looking at mast cells. And one of the odd flukes about mast cells is we are taught kind of the IgE classical role that mast cells play in all of our education as a basic research, and I think as clinicians. But mast cells do enormous. I mean, I kind of say, they're like Superman of the immune cells, and they do everything. And so when I was studying myocarditis, everything I was looking at, their roles were atypical. And so I feel like everything I learned there was just, a preview to helping me work with EDS when that happened. So that was very exciting. So here, the building in Florida is actually not pink, but this is at sunset on white tiles. So I just love the picture. So you saw this picture already, and I really just want to point out from this paper, when we were looking at what was similar and what was different, the thing that always comes out really clearly is allergy or anything like classic mast cell symptoms are common and they're extremely prevalent. I'm not going to get the number accurate off the top of my head, probably at least 80 or 90% of our patients, whether they're HEDS or HSD, complain of all kinds of allergy symptoms. So that's something that we don't see any differences in. And of course, what we see is that many people have also reported in the literature about how important mast cell issues are in EDS. So here we're going to hear just shortly from Dr. Maitland with studies related to that. We have other studies, right? And so we see that many people have seen that there are their issues and they report on that. And here's like a very recent paper also associating with a number of other EDS type symptoms in mast cells. So I'm just going to go over a little bit about mast cell activation syndrome and the diagnoses for that and what kind of issues we have. So Dr. Bruno mentioned how we have, enormous problems when we refer our patients to clinical immunology at Mayo Clinic, because basically the immunologists there say, we don't see any mast cell issues going on, and they don't want to treat them, and they don't see mast cell activation syndrome evidence either. And really they're basing it on these studies by Akin and Metcalf. And for those who know, Dean Metcalf is really, legendary mast cell immunologist at NIH, so very well respected. Okay, so what we have here is a classification of disease associated with mast cell activation in Table 1 on the left. And you can have primary, secondary, or idiopathic. And then in Table 1, it lists co-occurring symptoms that can be associated with that. And so you can see a whole list here. And I'm going to use this table when I show some of our data as we go on, because the mast cell experts say, all these kinds of specific symptoms, if you look at flushing, rashes, itching, anaphylaxis is a classic, wheezing, even things like bone and muscle pain. Interesting. So they're saying these all could be associated with mast cell activation syndrome. And so that paper was like a prelude to them coming out with an actual diagnostic criteria this is still 2010. So what they proposed in 2010 was episodic symptoms consistent with mast cell mediator release in 2 or more organ systems. And so they listed some organ systems here. And then they said a decrease in frequency of those symptoms if you give mast cell medications, and then evidence of increased mast cell activation. And if you look at different biomarkers, and they didn't really specifically focus on tryptase in this original report. And then they came out in 2011 with then a more formal classification. And so this has been referred to as Consensus 1. But from clinical immunologists, you think of Mayo Clinic or other places, this is really the diagnostic criteria that they say this is, what we need to go by. And so here it's just refined a little more from the paper that we saw before. So you can say Table 2 here. You have typical symptoms, which they say see Table 3. So here they say they have, with all the experts, and there were many more authors on this paper, they said they have great confidence, depending on these percentages, that these kinds of symptoms are really, it would be associated with mast cell activation syndrome. And of course, they're occurring in sort of different organ systems. You need then an increase in serum total tryptase, at least 20% above baseline, and within 4 hours of having an acute event. And you need to respond to some kind of mast cell blocking treatment. And you have to have all 3 of those in order to have a diagnosis of mast cell activation syndrome. And so in reality, this is very difficult to actually accomplish. So one, when we have our intake time, when the person comes for their their diagnosis at the EDS clinic. And so you saw from the workflow, we collect both clinical blood draw on that day and we do our research blood draw on that day. So the chances someone is having an acute event, right, is going to be random and probably not very many people. So we just call that a random draw. And so it's very difficult, to have someone come in. And I'd say at Mayo Clinic, it is almost impossible. With a doctor's order, you would probably, 1 to 4 hours, you would like very unlikely to ever be able to get in and get your blood on time. So it's just impossible. And it might vary at other institutions, but that is a major problem with ever getting a diagnosis here. And you have to work at what is the baseline trip days to really understand this. Okay, so then we had, because I think, I'm not sure the history of this. I don't think I know any of the people on here because this is not specific for EDS per se, but clearly became a problem. I don't know if EDS patients stimulated this or not, or if it came from a different history, but this has been called consensus 2, and there's a very large number of immunology mast cell experts on this paper. And they say, well, the other list, we're not the only experts. We're experts also, and we have a different opinion about this. And um, and so, they realize the problems, the innate problems I just mentioned about trying to get a diagnosis with consensus 1, and that there's a lot of problems, and they think that there's maybe something else going on. So what they basically did is they relaxed the requirement for the trypsin value in consensus 2, and they relaxed the need to show that the medication reversed the symptoms. So what are you left with? Well, they provide a very long, you can't read it here, but basically this is, every organ system, and what fell off the end here is immunology. And lots of symptoms listed here. And, you saw this paper from Dr. Bruno earlier. This, we looked at, I think, 120, and this one, 130. We have more symptoms and comorbidities than that in our questionnaire. And many other people sitting here, and I know looking on remotely, have done these same types of survey questions, right? And you have a huge number of symptoms in every organ system that are affected in EDS patients. And so basically, I'm like, well, I know we're thinking about renaming maybe the condition, and it's like, well, these are so remarkably similar. They may not be identical questions in both, but maybe we should just rename it mast cell activation disease, which I didn't go into great detail here. It has its own definitions as well. But because it's so remarkably similar, I think, the real problem is that we as patients and we as practitioners look at these patients and go, I see all kinds of things that could be due to mast cell activation going on. And yet our clinical immunology colleagues say, I see nothing is going on. And we're like, wait a minute, right? This is a huge problem in the field. So I consider my training as a PhD was an immunologist. And then, there's this strange quirk I kind of mentioned that's completely arbitrary, that there are immunologists and then there are mast cell biologists. I don't know how this happened. And if you read almost any immunology paper about any topic, they will never mention mast cells. They are omitted completely. And then you go to the mast cell literature, and they're hyper focused on mast cells to the exclusion of almost all the rest of the immunology. And so, there's a problem in actually the immunology field that's completely arbitrary, that's also compounding our problem here. And part also is what I see in the textbooks and what I'm assuming is going to be similar in medical education. Every doctor I've talked to has said we got almost no immunology. Everyone's afraid of immunology, and then it's turned out that like almost every disease, every chronic disease we're looking at involves immunology. So we have a vacuum there also of real expertise. So none of these are purposeful, but that's an area that we really need advancements in. And another area that's a huge gap then is any understanding that if we're not even getting good education in like classical IgE mediated, mast cell behavior, and then mast cells are doing 20 million other things, which are not, then we really have a big problem in understanding all the capacity of what could happen. And a huge gap that I see is we don't have any good ways to quantify widespread mast cell issues, which is at the heart of what we think we're seeing right in EDS patients. So issues with diagnosis, consensus one, the real problem is probably underdiagnosis, right? There's really a focus on that we're just looking for anaphylactic responses. And I think that absolutely is part of the patient experience with EDS patients, but we have so much more that is all these other areas of mast cell behavior rather than that. And again, I mentioned the almost impossibility of actually getting measurements that they require for consensus one at most institutions. And then we have now what has developed a whole philosophy or something that the clinical immunologists are just completely convinced. They're upset about consensus two. They're upset that in the EDS world we seem to be saying everyone has mast cell problems, and they're just upset. And consensus two then is a problem with overdiagnosis, because we have this great list of almost everything in the body could be due to mast cells, but we don't have anything quantifiable. We need something quantifiable. We need something we can say yes or no or degrees of severity, so that we can do evidence-based research and that we can say, oh, if we're going to give a treatment, there's lots of clinically available mast cell treatments. How well do they work, aside from anything new we might come up with? And if we don't have any way to quantify how severe people are, if they get better, how do we know if anything's working? So this is a major gap, and this is not just for EDS. I see this a gap in immunology in our healthcare system for many chronic inflammatory diseases. I believe mast cells are central to what is going on, and we need a way to really know what's going on. I would just point out, so this is what Dr. Bruno showed earlier, right? And we have our immunology and allergy here, 70% bad experience. And I can just say personally, with a person with EDS going to immunology, even as a, expert in the field, I was met with hostility, complete closed door. It was a very, very bad experience. And so this is immunologists at Mayo Clinic, clinical immunologists. And I don't know if you saw this paper. They recently did a systematic review of the literature and concluded that they couldn't find any evidence of a relationship with mast cell activation syndrome and EDS, right? And so this is part of this very negative. So they feel like they have evidence, but of course, not finding anything isn't evidence of it not being there. But that's an important point. So I think this is just typical of the problem. So I have very, very good news in that I had a previous student when Dr. Gonzalez left. They hired this person. He was my previous student. He's very open to research. I've met with him, and he is completely on board and wants to change the atmosphere of the immunology. So I'm incredibly excited to say I think we have someone that is really going to change the atmosphere there and wants to work together to sort of revolutionize what we're doing. And so I'm going to describe the mast cell score that I've developed to try to fill this gap, and really want to collaborate with everyone. I'm right on the verge of publishing. It's not published yet. And then, hopefully this will be useful for everyone in the field. It's very simple and easy. We can quantify what's going on. And he has looked at everything, and he is very excited and thinks that it's a really good thing to move forward. So we heard all about the intake questionnaire. At the moment, we have like 1,700 questions. So we had a patient here say, it does take quite a while to do the questionnaire, yet we've had incredibly good feedback about it, that patients really feel validated when they do it. Maybe for the first time, they look through all these questions and they're like, oh my gosh, they must know what's wrong with me because all those things are listed here. So I really based this on my symptoms. So, and what we needed is, you saw the list of symptoms like nausea, headaches, migraines, so many things. We can't base it on any of those because they can be caused by 10 different conditions, right? So we needed something that is definitely caused by mast cells and well known to be caused by those. So I picked things like that. It is a little IgE heavy, as it would be, because that's where all the research is. So I picked 11 categories of mast cell issues. This is self-reported. So the patient says, do they have environmental allergies, asthma, atmy, was asthma as a child or adult, venom, stinging insect allergies, food allergies or intolerances, drug or chemical allergies, allergic rhinitis, dermatitis. Have they been told they have mast cell activation syndrome, or have they been, told they have the tryptase mutation? So I based it really, if you've ever heard of the ACE score, the Adverse Childhood Experiences score, they ask you, did you have abuse as a child or a parent that was incarcerated, and it's all self-reported. And then for every yes, you get 1 point. And so they came up with a score. And there's just, I don't know, I think hundreds of publications about how well that score has shown the role of adverse childhood events in disease. And so I thought, well, that is a great mechanism. So we did the same thing. So there's 11 questions here. Each yes is 1. So you can have a mast cell score from 0 out of 11 to 11 out of 11. And what you see in the diagram here is when we were looking at 3,500 patients, that what their answers were to the score with each diagnosis, with HEDS in gray and HSD in blue. And they're almost identical, basically. And you can see that most people are in the middle somewhere. We have some that say none. Doesn't mean it's self-reported, so it might not be accurate. But what we're looking for is widespread and not accuracy per se. Because if you have widespread problems in all these areas, I mean, you must have something going on, right? And we didn't really get any had everything. So here shows some of our initial data. So this is just showing the data, and we wanted to say, if we compare people with low mast cell versus high mast cell, what does that show us? What do the people with high mast cell issues look like, and how well is the score reflecting these kinds of issues? So you can just see here, we took out the scores from 2 to 4, and so what we did is, 0 would have been best, but what we wanted to do in statistics, if you can compare equal numbers, it's much better, especially when you have such a large N. A large N will give you statistical significance almost because of how big it is. And so we picked 0 and 1 as low, and 5 or greater, and they were almost equal numbers. And so you can see that right here. So we had about 600 in each group. And so then this is just showing odds ratios, looking at elements of the score. It's not all 11 because some of them had crazy confidence intervals. But it just shows that if you have a high mast cell score in any individual self-reported component of the mast cell score, you had really high relationship. And then we looked, I picked symptoms that came from the table from Akin in 2010 and Valent in 2012. And they, some of them are the same. But it basically then, we had those experts saying these are mast cell activation syndrome symptoms that you can have, right? And we see that we get quite good, if you have a high mast cell score, you get quite good odds ratios of that being increased. And for Valent also, the list that he gave, not everything's on there again, but. So here just shows you, I wanted to highlight, because if you've done these kind of studies, or even if you look at some of our previous papers and we show percentages between groups, so we have a bunch of mast cell associated, many of them the non-specific kind of symptoms here. And these two columns are the EDS, low versus high, and the HSD, low versus high, and we're just doing pairwise comparisons. And so what we see is they're all significant, but almost all. But what you see is some of these are really quite high increases. So if you look at nasal congestion, you'd expect that with high mast cells, but it goes from 32 to 85 and 35 to 90. So you're really getting big increases. If you do these other things, you might have 70 to 85 or something percentages, it can be significant, but these are really big differences. And something like what throat swelling, 10 to 60%, 11 to 42%. And what's this one? Hard for me to read up here. Urticaria, 13 to 60%. So we're really getting, it's just sort of internally validating. This makes a lot of sense that these are increasing like this. Okay, so now let's get to some of the clinical measures we do routinely at Mayo Clinic, trying to say, do these patients have, do they have mast cell problems by looking at blood? So again, these are all random. These are not during an event because they come in when the patient has their initial appointment. And so on all of these, you'll see if you can make out those little red lines that go across above or below, those are what are the clinical normal levels. And then, and in each of these, we had about, it says at the top, 50 per group. So we just randomly picked people that had low mast cell scores and high mast cell scores from this to get a group of patients. And so the overwhelming thing you see is that there's no significant differences between low and high, and almost nobody is above the background normal. Now, of course, for tryptase, this is not what is the patient's baseline. Is it 20% of baseline? We don't have any of that data. But this is what the clinical immunologists at Mayo Clinic have been using to say, is there a problem? And they see no problems. So we actually looked up, the few that we have in each diagnosis here. So on the left of each group, of course, is HEDS, and on the right is HSD. And we looked up the individual ones that were right on the line or above, and 50% of those patients got a diagnosis of mast cell activation syndrome. And so you see from just the sampling, we're not getting very many diagnoses at all, and this doesn't match the mast cell score. Is there something wrong with the mast cell score? Let's see. Okay. The other thing that we collect is a random urinary sample to look at downstream mast cell activation markers. So we have methylhistamine, right, and PGF, and leukotrienes, and so the top row again is what the values are, and what we're showing on the bottom is because people drink different amounts of water, and these are proteins, so we have to adjust for that volume, and we do that by measuring their creatinine level in the urine and normalize to that. So these top row are all normalized, and what you see is none of them are significant with the high mast cell score, and almost nobody is above normal levels. And when we look at creatinine on the bottom, what was really remarkable is that we found only for HEDS patients, and we need to look at more patients and see about this, but we found that the high mast cell group was significantly changed for EDS in each of these. What that means is it was lower, significantly lower for HEDS patients, the creatinine levels. That means you can't use creatinine to normalize and that the values are inaccurate. So we need to look at more of these and see, could this be happening with HSD? Is it truly only happening with HEDS? Not clear why that would be, but most importantly, it's inaccurate. And this is what we've been basing our values on clinically. So then when we look, so now we have our random blood samples that we banked, and we wanted to look at mast cell markers to see if they would go with the mast cell score. And this we did in our lab with ELISAs. And so, because everything else was done right with the Mayo clinical labs. And what we found then is that these markers match the mast cell score. So most importantly, IgE, which is the most associated marker I think you can have for mast cells and classical mast cell activation is increased with the mast cell score. Of course, most of the things that we have in our mast cell score are, have been shown to have an IgE relationship. So that's not a surprise for that, but it's like the kind of gold standard of a marker. And so they went up in both diagnoses with the high mast cells. Also, our tryptase by ELISA, we saw that go up in HEDS patients. And then we saw this is major basic protein, which is a major product from eosinophils. Eosinophils have to have mast cells to activate them. So they're a different immune cell that is activated. If you have eosinophils anywhere, it's a bad diagnosis. That is not a good thing to have happen. And this is a product, and we saw in this case that the HSD had that. And actually, we've looked at lots of different markers, which will probably come out in a different paper where we see associations with lots of different mast cell markers. So this then is like, well, even with a random sample, we can definitely get a relationship here. It just looks like the ones and the way we happen to be doing it clinically at the moment. I don't know what it works for them, like other conditions. It must work. I haven't gone an extensive lit review to try to work out where they're getting positives, but it's not working with our EDS patients to show what's going on. Okay, so then and we'll show in the paper, we looked at all the areas. We have symptoms. We look a lot of symptoms, symptom tables for every area that in the body, and that I'm not taking the time to show you. But one area that was really fascinating and we think is really important, and this had to do with psychological issues. And so, we know that there's quite a lot of anxiety in EDS and depression. And so depression was like an internal control. So a high mast cell score, nothing to do with it. We do not expect mast cells to have anything to do with driving depression, although it very much could have to do with anxiety, because many of the mediators that release, many people have experienced hay fever, and you start sneezing and everything, and you often feel irritable, right? And that's just a perfect example of how immune cells release mediators that affect nerves and the nervous system. And so you can really have anxiety affected. What really stood out is like we really had almost no significant relationship with any type of psychological issue except for abuse and PTSD. And those were very dramatic. So if you look at those numbers, we go from like 30 to almost 60. You almost have a doubling percentage of people self-reporting abuse. And if you look at the bottom, you see the types of abuse, right? So emotional abuse is really the largest, physical abuse, and sexual abuse, and then PTSD. So I brought in the A score. So we have the A score in our questionnaire. And so this really tells us if they had childhood abuse or bad conditions, and we see significant increases with that. And here, we're almost finished. We have looking at these just to see the odds ratios for all of those categories. And this is a distribution of our A score, which, as we would expect, these are 10 questions that are asked, and they self-report again, similar on all these categories. So most people didn't have it. And then you see it going down. We had some that had many, many issues in their childhood. And here you see the A score for each diagnosis with this large increase. And so we know that many people have written about how important stress is. Like mast cells are at the center of the stress response. So they respond, of course, with the neurological system, the immune system. They're completely different by sex. That's an area that I've always been researching. They also sit right in the middle of all the stress hormones. And this is just showing how you can have cortisol released, and you have these other, you have cortico-releasing hormone, neurotensin substance P. But what happens is this can drive inflammation. And this cortisol is often anti-inflammatory, but in stress conditions, it may, in this case, not really be promoted. And then there's studies that have really, with other models, have shown how stress can really affect, you have each type, behavioral changes, acute stress, chronic stress, and all kinds of different changes that can happen related to that. So in summary, consensus 1 is likely going to give us an underdiagnosis, consensus 2 an overdiagnosis. Blood and urine markers, just in our experience, they are not helpful. The MASL score, I hope, can be helpful. It's just 10 easy questions. I think that, a little questionnaire could happen. You could send out before they have an appointment, or even when they're in the waiting room ready to come into a point, and then you have the score and you know how widespread a problem someone has. We found almost 20% of all of our patients had a high MASL score. It associates with these widespread mast cell related symptoms and also with blood markers that we've looked at. And so in the future, we want to define the middle group because it's probably also very significant things going on there. Validate with blood and urine markers and larger numbers, validate at other sites. We have sequencing data that we're doing and hopefully something we're going to publish soon. And we're also doing large language models and AI and use the mast cell score to examine EMR data on a large scale to try to see what patterns could be there. And we also are exploring the effect of abuse and PTSD on the symptoms and comorbidities. Sadly, the United States has some of the largest abuse percentages of Western countries. And, it's often just a very overlooked area. So I want to thank all the people in my lab. Frances Wilson is here. She runs the daily management and research for our EDS group. And then you can see Caitlin and one of her students right here because we are tied at the hip. And of course, with Dr. Knight, we're working in close collaboration. Even though he moved away, now we have like joint research ventures, which is very exciting. And of course, many lab members. And I thank you for your time and if there's any time for questions.
We do have time for a couple quick questions. Yeah.
Yeah, so I'll repeat the question. So she asked if mast cell activation syndrome can be involved with delayed type hypersensitivity response. So I personally have experienced everything, and I see it fully involved, even though they're separated. I think basically from all the research I've done in myocarditis and the literature and my own personal experience as a patient, I see every type of activity that mast cells are capable of doing being involved in EDS. So we need a very widespread description rather than a narrow one for what is going on. And I would not be surprised, we have to do the research and prove it, that mast cells are actually involved in most of the problems that we're having. Not all. I mean, we talked about congestive, pelvic congestion, right? So are they involved in that? Well, they might be. You have a loose and floppy vessels. Well, if collagen isn't actually missing, maybe the mast cells, because they break down matrix and they build matrix, right? In one person, they may break it down and they have a floppy vein. In my case, with mine, I had fibrosis and it was built up. They might be responsible for everything, or it might be physical, and we have to prove what's going on. But I think they could quite possibly have a role in a majority of the symptoms and comorbidities we have. Yeah. Yay! Yeah. 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 Exactly. Yeah. Yeah. There's a big challenge. Oh, sorry. So to repeat the question, we have so I'm a mast cell biologist in training or already in training, and so he's asking. Normally we do blood biomarkers. They're the easiest. It's the least invasive to get a lot of our information, and will we have to move away for that, or what role will that play? And so there's a huge problem with mast cells. So if we think of the other immune cells, so for example, my corollary is T regulatory cells. They're in tiny, tiny amounts. Mast cells are in tiny, tiny amounts, but they control everything. They're master regulators of what the outcome's going to be. And so people understand that, but they don't understand it when it comes to mast cells. Mast cells control everything, and they're very few. The biggest problem we have is that what is in the blood are basophils, and they do not behave like tissue mast cells. And so those two, that's a big obstacle we need to overcome. So we really need to get tissues if we can. So any more?
Yeah, I think we have time for one last question. Yeah, go ahead.
Mhm.
Say a little bit about what therapeutic and diagnostic approaches you take, not just antihistamines, but mast cell stabilizers or other things to interfere, and that would both confirm your hypothesis of causality as well as is it part of the therapeutic paradigm that you're working on?
Thank you. So the question was, what is kind of, I guess, our clinical next steps and how we can prove this paradigm and what we could do with the current medications. So what I'm working on, I am concerned that if we, and why consensus 2 relaxed probably whether the medications work, is I have the concept that we have to remove our baseline. I think we have mast cells being activated all over our body. It creates this high baseline of reactivity, and we need to get that down. And so something that I think is a central issue has to do with our diet and our interaction with our environment, as the highest number of mast cells in our body are in our mouth and our throat, every mammal. And their primary role is to monitor the environment and send all the alarm messages for that. And their number one thing was toxins. So that's like venom toxins, snake toxins, all those enzymes they release. They're I think the only immune cell that can break those toxins. And our world, especially in the United States, our food and our water and everything is full of toxins. And so what I'm working on is a mast cell centered diet to bring that down. And I think with the mast cell score, and if we can get the baseline down, we're going to start to see much more effectiveness with our current medications. In my personal experience with this, I brought my baseline down, and then suddenly all the mast cell medications started working, and they never worked before. Because if you've got all this going on, how can they stop it? Like that's not going to be possible. So you have to get it calmed down first. So that is our approach at the moment to this. And then of course to do clinical trials with currently available things, and then see if we need innovative things, right? Because we're out of the box how mast cells may be causing some of these symptoms, not just classical view. And with that, we may be able to come up with new, more effective drugs, might target mast cell activation, and if it's one area, POTS, or specific nerve symptoms, or, maybe we'll even in more precision than just a histamine blocker. Okay.
Thank you.